So I will call to order the May 26, 2022 meeting of the Panhandle Health District. I would like us to stand as we pledge allegiance to the flag.
I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation under God, indivisible, with liberty and justice for all.
Thank you. You may be seated. As you may be aware, we have a new member to our health board, Thomas Fletcher. And we would take this quick moment to welcome you to our board. May you find this a fulfilling, rewarding experience. You have joined a board that is very serious about the work they do. And I don't know your past experience on boards, but I'm going to tell you right now, this is one of the finest boards on which you will ever be a member. Okay, welcome.
Thank you. I'm humbled.
Thank you. And with that, we come to the public comment session. And here is a time when we give 3 minutes to anyone who wishes to make a public comment on something having to do with the public health. There are certain guidelines that you see on the agenda. Is there anyone here that wishes to take advantage of their allotted 3 minutes for public comment? Anyone here? Second call. Last call. Sounds like no one is here to deliver public comment. So we will move on with our agenda. First item on our agenda, following our public comment session, is the consent agenda. And you have mainly 3 items in the consent agenda today. The minutes from April 28 and...
Recording in progress.
Thank you. Glad to know that. And we have the division reports and just one contract having to do with tobacco prevention. Is there any item in the consent agenda you wish to pull for further discussion or question? If we had an extra moment, I would ask Eric, do you have anything in your area, your section here, that you want to just briefly comment and highlight? You don't feel like you're on the spot. You can just say no if you wish to.
Not at this meeting, Chair.
I'm sorry?
Not at this meeting. Thank you.
Okay, all right. And do you have anything you wish to add?
I do not.
Okay, but I want you folks to know how much I do appreciate the written comments that you have in the consent agenda. All right. I would entertain a motion then that we receive and approve the consent agenda as presented in your packet.
Mr. Chairman, so moved.
All right, we have a motion. Is there a second?
I have a second motion.
A motion and a second, and we've already asked for discussion, so we don't need further discussion. All in favor of adopting then this consent agenda as in your packet, indicate by saying aye.
Aye.
And opposed, no. All right, is so ordered. Thank you. Probably the bulk of our meeting today is going to revolve around the very next item, and that has to do with the IAB June 9 meeting. And you have in your packet, you have a proxy. If you wish to sign your proxy, I would suggest, as we will find out as we progress here today, I would suggest that you sign your proxy over to Glenn, and you'll understand why in just a moment. The IAB will be a virtual meeting this year. I don't know just how this is going to do. It's hard for me to imagine how in a virtual meeting we can do justice to resolutions. But I'm just a dummy, and it'll probably go over just fine. But I'm used to being at a meeting where we are all in attendance, rather than trying to do resolutions and discussions in a virtual meeting. So at this point, I think it behooves us to turn the meeting over to Glenn, who has gone through these resolutions rather thoroughly. And I want him to give his suggestions, how he feels this might work smoothly. Glenn, you have the floor. What can you do for us?
Thank you, Mr. Chairman. Fellow board members, I think if you turn to page 14, under tab 6, you'll find the proposed agenda for the 2022 annual conference business meeting. And down under the review of expiring resolutions as an action item, you'll note there's 6 resolutions that would be considered. And it would be my recommendation that we continue those resolutions, or continue to support those resolutions as they stand. Dr. McClanders, did you have a question?
Could you define an expiring resolution? It was a timed resolution from before, and now it auto expires in this week.
Yes, there's usually on an annual basis,
Yep.
we reconsider these resolutions, whether that it's something that we can still support, it is still needed, or whether or not we need to just go ahead and put it out in the historical database. So these resolutions to support evidence-based home visitations, supporting immunizations, supporting raising the minimum age of legal access to tobacco and nicotine to 21, supporting, now, if the legislature puts these into law, then there's no need for them to continue. But at this point, these are still issues that are being considered, and I think they are things that are still needed and that most of us support. So that's why we're reviewing them before we meet on our annual meeting to support or withdraw our support for these. Is there any thoughts, comments on these resolutions? Marlon?
One of the problems I see with this system is that so often, if a resolution is voted down at the IAB, there isn't a good system put in place to get these things into the hands of legislators who take them to heart and push and promote them and get them into
Idaho code.
Idaho code. Is that?
Well, even if the majority of health districts no longer support one or more of these, we could still lobby our legislators to represent us for their approval. So even though the rest of the other health districts don't necessarily support them, but I haven't seen that happen.
Right. That's,
So
you see,
that's kind of far out there, but yes, we could continue to push for legislation.
and when the health district was younger, you see, there's some notepads floating around that says something about the health district being 50 years old. But back in its youth, when there were issues that involved more of the entire state of Idaho, and it would get the attention of legislators who would then push this through for a vote to get it into Idaho code or else not into code. But if you look at a lot of the current resolutions, they have a tendency to deal with an issue of that local health district. And so rather than this being a statewide thrust toward getting something into Idaho code, it boils down to being a health district push. If we think it's important enough to really get into Idaho code. So this is where sometimes I think the whole system needs to be rethought, but we can't do that now. We still have to do something for this IAB coming up the 9th of June.
So that's why we're discussing these issues, these items, whether or not we as a board or, District 1 can support these or not.
See, now with the proxy, I don't know how many here. See, what is it? The whole meeting that used to be 2 nights and most of 3 days is now being stretched into 2 hours.
A Zoom meeting.
So I don't think I want to travel to Boise to be a part of a 2-hour meeting where little to nothing will be accomplished.
Well, in my opinion, it is rather difficult to have a discussion of a topic or an issue and get all the inputs and see their facial expressions and read their body language. It's really hard to do when you're using Zoom. To me, it's an inappropriate way to conduct a meeting on issues that are so important.
So then, Glenn, question to you. Do you plan to take in this 2-hour span of time June 9th?
Oh, yeah. Even though I do not like that system, that way of doing things, at the same time, I recognize that our voice needs to be heard. And, we have an opportunity to speak up and state our position on these various topics. So we need to use it and push in the future. I think Zoom is not the way to do it, folks. We need to do this face-to-face, in person.
Okay, now having said that, if board members felt comfortable and wish to trust Glenn in his wisdom, you could easily just take your proxy and sign it over to him, and then he could have a block vote. It doesn't have to be a block vote. It can get really hairy sometimes when all 7 districts are together, and then you have to count. District 1 has this many yes votes and this many no votes. But it's very hard for us to look at these resolutions and say, well, I'm going to write a proxy, a no vote here and a yes vote here and a no vote here. Because remember, at the actual meeting, the proxies, the resolutions, the resolutions can be amended and changed. And so you might sign a proxy over to a person and find out at the actual meeting where you are not in attendance that resolution just got adjusted to where you, if you knew about it, would change your vote.
That makes it difficult.
And so as we try to deal with this in this manner, the thick plottings. So it would be my recommendation at this point to, if you felt comfortable with Glenn, to sign the proxy over to him and say, Mr. Glenn, go for it. See, Glenn has been working with this supposedly on a monthly basis throughout the entire year. This year, there hasn't been trustee meetings every month. But still, if there has been a trustee meeting, Don and I, yes, have been in attendance and are much more aware of what's happening on these issues than at least I do. Now, keep in mind, this IAB is being hosted by District 4. So if we really want to think about making some changes, we have a year to think about it, because guess who hosts the next IAB a year from now? District 1. Mm-hmm. We always follow District 4.
Very true. Well stated. Okay. So is there any input, Dr.
If I-
McLanders?
Understood on the expiring resolutions. Upon reviewing them, your thought is that the board could consider recommending to continue them and not let them expire,
Yes.
to keep them on the docket because they're important to us and we want to elevate them to the legislature. I support that.
Correct.
Yeah.
Okay. Are there any questions on these resolutions? They are included in your packet, so you've had an opportunity to review them and consider those. But if there's no other input, my inclination would be to support all of these resolutions being continued and not archived.
Okay, hearing that, see, I think maybe you have just one copy of the proxy designation in your folder, but we could easily deal with these expiring resolutions with one motion if you wish to sign it over to Glenn. And then we could move on to the new resolutions. Does that sound like a workable plan? So here again, if we give these proxies, I'm not telling you if you want to separate any of these out and for yes or no, you can, but we hear our trustee recommendation is that we continue these. So that would just take one vote and one proxy for the expiring resolutions. What is your pleasure?
I can voice that I'm supporting the continuation. So-
All right.
So I can either by form of my own
All right,
or as a group.
is that your motion then?
No, sir, I'm just voicing his position to see if that's the other position.
Okay.
I think each board member has the option of being on the meeting. So they have the option of
That's true.
signing proxy or being there and voting one at a time.
That's true.
Sounds to me like I'm hearing everybody's agreeing with Glenn's recommendation on the expiring. I haven't heard any opposition to that. And then we can indicate that on the proxy. I think your plan is to go through these next ones and decide if we're going to break them out or,
Get your opinions.
Yeah.
Okay. All right. So there's no further discussion on the resolutions to be continued. Why don't we move on to the current review of proposed resolutions? Item 1 is the support on an excise tax on electronic nicotine delivery systems. Is everyone familiar with that resolution?
Give us some
Any discussion?
top points on it.
Um,
Of course, where, no, see, that's in our,
1903.
let's see if we can find that one in our.
there's still evidence that tobacco products that cost more lead to some decision-making for less usage. That's the whole point of it all.
Yeah.
Especially among young people. So I'm certainly in favor of supporting that.
I think that evidence shows that when you put a price tag on an item, that it makes it prohibitive for certain younger members of our population. And that's the objective here, is to reduce the electronic nicotine delivery systems that are very addictive. Okay, other discussion on that?
Sounds like that's a support.
Okay. Next one would be to remove the food establishment license fee in Idaho code. Currently, the health districts are the ones that impose those fees, and the health districts come together to come up with a fee every year?
Yeah.
Or so?
Mr. Chairman,
Don?
Mr. Kettner could offer more on this, but that is, the state actually implements what those fees
By
are.
code.
Yes, by code. Mr. Kettner may have more to add on that, Mr. Chairman.
Mr. Chairman, Dawn's correct. Those fees are set in code. The health districts have come together in the past, most recently in 2018, and agreed upon and involved stakeholders such as industry lobbyists and so forth to come up with an agreeable fee. And then those go to the legislature, and then those are set in code, which does eliminate the health district's latitude in identifying other fees for those same services.
So this proposed resolution is an attempt to bring this to be a more localized establishment of those fees. And as I understand it, it was District 4 that was heavily proposing this.
Mr. Chairman, I believe District 3 spearheaded it. Yes, yeah, they tend to work pretty closely in tandem.
Okay. Now, the positive side of this, I like the idea of localized control. To set a fee that is statewide, you've got a lot of rural counties, and then you've got 3 and 4, which are more urban. District 1, we have Kootenai County that has a larger population. The rest of us are rural counties. So I kind of like the idea of the districts being able to establish this with input from their counties. Fortunately, District 1 has been able to manage these fees and keep them fairly low, and I think that's a good thing. We can continue to do that, but we would have the ability to raise or lower those fees as our research shows whether or not they should be raised or lowered. That's my opinion.
Okay, my question would be going to Eric again. Is it true that the food fees in District 4 are, even though they are a tighter knit community, that the food fees in District 4 are higher than the food fees in District 1
Maybe the costs.
in cost?
Yeah, Mr. Chairman, when we spent quite a bit of time with this in 2018, and the outcome was is that District 1 did make the most efficient use of the fees that it did take in. The license fees were covering, I believe, around 47% of our program at that time. Other districts were seeing, 20% of their program. One thing to comment though is if we're looking to have these fees cover the cost of the program, the food safety program is by far, and I don't think just for our district but others, the one that consumes the most district funding. So we would certainly be looking at an increase in fees if we're looking to cover the cost of the program through the fee.
And we could charge up to, but not over.
Mr. Chairman, I think that because it's set in statute, we charge the fee that's set in statute. That's what we do.
Okay, so, other discussion? So, by show of hands for my benefit, do we support removing the food establishment license fee in Idaho code? And if we support that, then we would have to take it to our state representatives, legislator, to let them know what our position is, to get their support, because it would have to be done legislatively. So.
Question for Eric. Do we need those food fees to help fund our work done to do the investigation / work done? It's a big part of our budget, right?
Mr. Chairman, that is correct. Complaint follow-ups, investigations,
Right.
outbreaks, that all consumes money from that
Right.
law.
So if this resolution goes forward and this legislature then removes the state code, then each district would need to address it, correct?
Mr. Chairman, that's correct. There would likely be a need to have another rule set that authorizes us to charge fees. That's how the septic permitting, there's a, that grants the boards of health that authority. So if it would have to be done concurrently, where if it's removed from statute, authority would also have to be granted to charge fees.
Right.
But then, Eric, wouldn't that have to be done for every district in the state?
That's correct.
Right. Each district would then be creating a new, call it fee code, that would apply to each county. And the new law says that if a health district passes anything that is a requirement of the entire population, and the 3 county commissioners of each county need to sign off on that for their own county, right?
Okay, but then how would we know that we were all using the same criteria to establish a fee?
Don had a comment.
Mr. Chairman, if in fact, and it's a big if, let's assume we approve this resolution, and then we find, first of all, we have to find a legislator that's willing to carry this and actually make the change in statute. There's a lot of ifs in that process. So let's assume it gets all that way, and they bring it forward. There is going to be a lot of resistance, not the least of which is the food industry is going to have a lot of resistance to this. They have made claims like, well, if something like this happens, we're going to find an independent agency to come in and regulate our restaurants. And a lot of bantering that's that went around a lot in 2018, as Eric mentioned. But let's assume this gets all the way through, and now we as a health district have the right to set those fees. It would be just like we do our other fees. For example, in clinical services, we have to present our fees to you. As Eric came forward to the board just last month to get our septic fees approved by you, it would be just the same with our food fees. And so there would be a significant discussion about what are our expenses, what does that look like, what can the food industry really sustain going forward. And Mr. Chairman, you are correct. We cannot make a profit on this. We can simply cover our fees, cover our cost with our fees that you would subsequently approve. But there is a lot to get to that point. And all we're saying today is it your recommendation that, as the resolution states here, that we remove the food establishment license fee out of Idaho code, and then the work begins if in fact that happens.
Work begins. This could be a process that could take a few years.
Mr. Chairman, it probably would take a few years, and it depends on going into the legislative session, how many items are already on the docket for them to review. And I believe it would be a challenge just to find someone to carry this. Who in our area would be willing to carry this to the legislature, carry a bill? If it's our area or even down in southern Idaho, it could be interesting. Yeah.
Dr. McClanders, I can still see the wheels turning.
Well, with all that being said, even it's been 30 years we've been back and forth on this. We've spent hours and hours on food fees. And I feel it's appropriate to have a state code that in our state of Idaho, we inspect our food establishments to make sure they're safe for our population. And we have the food establishments effectively pay for that process. It goes into their cost pro forma and as part of business. And so I'm opposed to, this resolution to remove the Idaho code.
Okay.
Other thoughts? Mr. Chairman, if I may. So if I may, with one other comment, and just so we're all very clear, and Eric alluded to this earlier, that difference between the fee and the cost is being covered by your counties. And if we got to the point where we could cover those fees with our own fees, that would be less revenue, less support we would need from the counties if that were to happen.
The counties were very much in favor of septic fees covering the actual expense, so the county didn't have to pick up the difference. And this is basically the same type of thing.
There's a huge hurdle that requires changing the Idaho code to make this happen. But do we support trying to do that? That's the question. Dr. Congress, no?
I thought Dr. Blanderson said that I do support separating out the fee, but maintaining the requirement for the standards. I think that at the local level, this specifically to me, is asking the question with respect to the fee, not the standard itself. So that's how I parse it out.
Well, okay, what this boils down to then, if you're going to fill out a proxy to give to Glenn, then you need to mark on your proxy whether you are in favor or whether you are not in favor. And with that, I think they're just about, do I see a hand over here?
Can I ask a question?
Pardon?
Can I ask?
Okay, you can ask a question, just if I may poll the board members to give you the permission.
May I make a
And
suggestion?
so
May I make
I-
a suggestion?
I need to poll the board members. Patricia would like to ask a question, and I want to know how many approve of allowing her time to ask a question. Any disapprove? Okay. All right, Patricia will give you,
It's more of a suggestion. If the food fee in the code is not covering the cost, then the code fee needs to be raised. That would be much simpler. That's my
See.
suggestion.
but see, we can't do that.
But you have legislatures who can.
Will they?
Assuming you can
I think so.
capture their attention.
Mr. Chairman, part of the reason for this, as we alluded to earlier, the fee, the costs to implement this are different throughout the districts in the state of Iowa. That's why this resolution came forward, that each could create their own fees, not just the same fee that could be different for statewide.
Thank you for letting me make my suggestion.
Okay, fill out your proxy and make sure you get it to Glenn, unless you plan to attend in person. Then that's your choice. All right? Okay.
So, Mr. Chairman, the next item is number 3, supporting raising the minimum age of legal access and use of mitragna speciosus or kratom products in Idaho to age 21. How many have even heard of this drug or item? Okay, Jessica, what is your knowledge? Because it was the first time that I had seen it was when it came up on this proposed agenda. So I'm not familiar with how addictive is it? Is it causing problems for our younger kids, or what's the situation?
It does have an addictive potential. It's certainly not the same as an opioid or, these sort of things, but there is an abuse potential that comes with this. People are using it. It's a natural sort of a plant derivative that can provide some pain relief. And that's typically what, in my practice, which is all pain patients, that's what I see all day, every day, is people using this in order to have a way of getting pain relief.
Okay.
And so, as with any of these substances in the developing brain, I think it's very similar to cannabis. I think there's no question that in the developing brain, none of these, we just don't know. Kratom has not been around long enough for us to have any idea. And in the interest of the health of the adolescents and teenagers in Idaho, I think it's absolutely appropriate to raise that age to 21.
Okay.
I would add background that for years laborers would chew this all day while working to allow them to live through the suffering. It has an opioid-like effect in the brain, and I certainly agree the developing brain is like at risk, and plus the adolescent who is potentially has extra access based upon being able to get this at a young age, categorically makes decisions based upon their emotions rather than what they know. So I certainly support elevating the age for access.
So if I understand this, the positive side is that it decreases pain in most individuals that use it. Is it addictive?
The-
And what are the negative effects?
Well, there are reports I just was reading about it, knowing it was on the topic, that the NIH does have, the National Institutes of Health, has research that confirms that it is addictive. That is, using it leads to desiring it more, leads to repeat use. There are.
So is it a gateway drug then?
Ga-
Gateway?
Well, that's a subjective comment. What is a gateway to opening to other drugs is what you're thinking.
Sure.
Never defined as that, but probably any drug could be called a gateway drug.
It's kind of like marijuana was considered a gateway drug to harder
Yeah,
drugs to get more of a high.
right.
But
Yeah,
to me,
Yeah.
this is such a new thing that its
I do think
negative
that's-
effects are to be determined.
Right, we don't know. So
Right.
marijuana was always considered a gateway drug. We now know that that's actually categorically false. It's not a gateway drug.
Mhm.
This medication or this substance, we don't know anything
We
about.
don't know.
We don't know enough even to use it in a medical sense. And so I think that the data is still inconclusive, even in adults in long-term use, because it's really emerged relative, even though it's been used for a long time, that this sort of craze has emerged very recently. You can go to the local, convenience store and get creative products.
fad.
Yeah,
Yeah.
exactly.
So based on that, my thought was, we still don't know. It's to be determined. So why should we take a position to support such a thing when we don't know the
Well, we do
the
know.
benefits or the downside?
We're talking about the adolescent brain. This resolution speaks to age 21 and open access. So to me, absolutely, I'm in favor of it because this is the developing brain. As you know, in adolescence, the reason we're crazy when we're 18 is our frontal lobe melts down, literally. The nerves kind of go away and then they reformulate when you're 29 and you're a male. So what I'm saying is age matters in this particular resolution. So
So
we're going to
you support this based on,
yes,
that-
right.
Okay.
I don't know what your thoughts are.
I mean, absolutely. I go back to sort of some of the cannabis research that says up until the age of about 30, like
Yeah.
you mentioned, up until that age, it really does have negative effects. And so it is an extrapolation because we don't know for sure. But at the same time, I think in the interest of protecting that developing brain, it's not that you can't get this substance as an adult, but you've got to get to that age first. So I agree with Dr. McLeiners on that.
okay, so if I have to defend supporting this, how would I argue for it? That it's the young brain up till age 21 is not able to deal with using this?
The decision to use it.
The
Yes.
decision?
And access to it.
Okay, so you're saying the decision is the part that they can't handle, even though we can't point to negative effects of this?
We know a lot, there are negative effects to it, as I've mentioned. We're learning, and it's commercialized now.
That's to be determined still, though, right? Not enough information?
We have enough information to know that there are negative side effects, definitely. And the articles referenced here and the details, I think, support that.
Okay.
Let's call on the Dr. Fletcher.
Thomas?
Thank you, Chairman. Well, you asked the question, how would you defend it?
Yeah.
I would say that in the absence of abundant data to give us biological guidance, I would say the burden of proof is in the direction of caution. That is to say, you don't allow something because you can't prove it's bad. No. You arrest premature implementation of potentially a psychopharmacological agent, and the burden of proof is on that community to demonstrate that it is safe. So to my way of thinking, it's common sense. The burden of proof is on the side of the industry that wants to push this.
Okay. So let people be the age of 21 when they make the decision to use or not to use.
Well, we
In
as a
other words, we're
society are
saying-
going to protect people younger than 21.
Okay.
I guess once you reach the age of consent, well, then you can do all kinds of things.
Yeah.
I mean, then we get into civil
But
liberties.
Legal, there's
Right, exactly.
no legal side to this at this point either. Okay. Okay, so
We can support this.
So how many support this proposed resolution, raising the minimum age, legal access and use to 21?
It's not conscious.
It's all of us
Sure.
that are here.
I think the discussion.
But don't
Yeah,
ask
because I was still,
Yeah,
I had a lot of question marks.
I was sort of.
Well, and bear in mind, I've never even heard of this thing. I have
Well,
no knowledge, but that's the very point.
I appreciate the discussion because I learned a lot that I didn't learn from reading. Okay. Next issue would be support vaping prevention in schools.
that's a no-brainer.
To me, I'm more familiar with the downside of vaping. So
Feel good.
how many favor this resolution? Thomas, did you have an opinion?
Do I have an opinion?
Yes, you
Oh,
can support this or?
yeah, of course.
Okay. All right, I'll support. And item 5, support innovative funding streams to support awareness, education, and prevention of suicide. I mean, that's a no-brainer. Everybody supports that?
Yeah.
As well? Yes. Okay. Thank you. That helps me when.
Mr. Chairman, if I
Yes.
may ask. Okay, so Glenn, help me understand here.
Mhm.
And actually, Chairman sort of made reference to this or alluded to it. There's potentially a lot of content here.
Oh, yeah.
I mean, a lot of content. And the devil is in the detail.
Mhm.
So for instance, let's take this last one. I mean, how can you not be in support of bringing
Trying to
awareness, education, and prevention of suicide? Well, that's a feel-good duh. But there's an awful lot of content here. How do you bring awareness? I mean, there are different methodologies.
That's the most
And this
effective.
is nuanced.
Yeah.
And so I go to your question, Mr. Chairman, how do you resolve all this in 2 hours? This is silliness.
Well, it's just like you go back to the one here on this kratom. Okay, so we vote in favor of that. How do you go about enforcing it?
Mr. Chairman.
Yes.
If I may, let's all bring ourselves back to what a resolution is. A resolution is something that supports a position that can be
Right.
further
State certain
explored and
position.
regulates, whether they go to the legislatures or whether they go to a larger mixed group for finding solutions and answers. So at this point, they're just asking us, are we in favor of having the state pointed in the direction?
Okay.
Yeah, we are not actually trying to solve
All
all
right,
the problems.
Mr. Chair.
This
That
is a-
helps.
This is a
Thank you.
resolution.
All right.
It's a position.
A position. Thank you.
Okay, to turn the floor over to our director for the next comment.
Thank you, Mr. Chairman. Yes, I really agree with your comment, Mike, on that particular issue. For example, on suicide, which we do a lot of work on here in the Health District. We're currently talking about getting funding for what's called Zero Suicide. It's a evidence-based program. And if we go and get funding, it's nice to have this resolution with us when we ask for that funding, showing that the boards of health throughout the state of Idaho support suicide prevention efforts. And it's not only just for taking it to legislation, but if we're going to go after funding, to have that support.
So in essence, when we're done with this,
Yeah.
We've gone through it. Oh, yes.
I'm sorry, Mr. Chairman, one more question, maybe for clarification. So these expiring resolutions, every 3 years, they're up for
Reconsideration.
reconsideration. My question would be, at what point, so if we're renewing these every 3 years, so for example, the opposition of recreational marijuana, the articles that is drawn from are extremely antiquated. They're 7 years old. No one has looked at that, and there's just blatantly false information in here about things that we've learned since 2016, probably. So my question is, if we all say, yes, we would like this to be renewed, then it just goes back into this binder for another 3 years without any updating to the vernacular or anything like that. Is that correct?
That's true.
Okay, thank you. And here, I think, is my answer to your statement. Then that gives us 1 year to adjust this, correct it, and propose it again next year as the host district for the IAB. Whether you think about it this way or not, the host district will have the most clout and able to present something.
But this resolution, sir, would not be up for discussion next year. So we would present a new one or an amendment to that, or how would that?
No, they're reviewed every year.
Yeah, and I agree with you. The information, the background data needs to be updated. We've got loads of information on states that have legalized marijuana as a recreational drug. What impact has that had on crime, on suicides, et cetera, et cetera? There's statistics to be found to support not legalizing this, I think. That's my position, but I haven't seen all of the data. But to get an update on the pros and cons, I think would be a good idea.
So if I'm hearing this correctly, if I were to agree to renew this resolution, then potentially next year I could be in charge of writing the new one for this, and potentially
That is
medicinal and all these sort of things with more updated and accurate information at that point.
We could propose an update or an amended resolution.
And I think before this meeting is over, Dr. Jameson, you're going to hear some comment from our director in support of having an IAB where we all come together at one location, the 7 districts in the state, and where we have time to really get to this and not try to just deal with it over the TV screen or whatever. We cannot do justice to this. I don't care how strong Glenn speaks on this, it won't have nearly the effect as if we have all 7 districts come together, but in one room.
But we need to prepare for that by requiring input a month in advance so that everyone has an opportunity to review the most current data and try to determine what position they'll take based on current data. That's a good thing.
I know it costs more for all 7 districts to come together, but Michelle knows how to organize these things. She's done it before.
But decisions need to be made on accurate and current data. So that's all I have to say.
All right, is there anything else then any comments on these resolutions other than prepare your proxy, make sure you get it either to this office or to Glenn. All right. All right. Where, here we are. Okay, on our agenda then, we come down to Jenna. Are you aware that you're next?
I am aware, Mr.
Well,
Chairman.
you have the floor, ma'am.
So, Mr. Chairman and members of the board, at our last Board of Health meeting, Dr. McClanders had a few questions about just demographics of the patients that we're seeing in the clinic. So we had a chance to pour through some data and put that together for you all. So you have this in your packets as well. So we'll just kind of go through this together and cover the high points. We've pulled data from 2019 to 2021 just to build kind of a comparison over the years. So starting on the first page, looking at family planning, that's always been a very large program within our clinical services. In 2019, 22% of our patient population was family planning patients. In 2021, that's decreased to 18%. So a slight drop there, nothing really alarming. Adult immunizations was really interesting. So in 2019, 23% of our population were here for adult immunizations. That has dropped over the last 2 years to 15%. So that is a substantial drop. Interestingly enough, throughout COVID, people aren't traveling. So if people aren't coming here for travel vaccines, that could play into that. But that's a tremendous drop. Children's immunizations also decreased by about 5% over that 3-year time period. And then also, interestingly enough, flu vaccines went from 16% of our patient population in 2019 to 33% in 2021. So that was a completely different swing on the flu vaccines. Care Plus has remained pretty steady. Care Plus is really our patient population that don't fall into one of the other categories. So they're not here for family planning. They're not here for STD services. This could be, I stubbed my toe and I'm here at the clinic to be evaluated. So it's kind of that bucket of that patient demographic, and that's remained pretty steady, a slight increase. STDs also remaining steady at about 7%. Women's health check as well. If you look over in that 2021 category in the yellow, the numbers to the left of the dash sign include COVID. We saw about 6,500 patients for COVID last year, so that really is skewing those percentages. So the numbers to the right of that dash sign have COVID removed. So that's a much more accurate representation of kind of a comparison between the two previous years. Moving to the next page, that's just a different graph. Go ahead.
Jenna,
Yeah.
I just had a question. On the COVID, as far as immunizations, vaccines, et cetera, they could have been available at other locations, correct?
Correct.
So that might have impacted your
Yeah,
scope of that.
exactly. And I guess I'll give you just a precursor. As we go through this data, there's a couple things at play that we don't know the answers to. Is it COVID? Is it Medicaid expansion? There's a couple factors that come into play here. So as we go through this, really we're looking at data, but we don't have the answers.
Yeah.
So, but it's interesting. It's kind of an interesting process.
Difficult to
Exactly.
what was the cost?
Exactly. And when I think we saw 6,500 patients for COVID, that's a substantial amount of patients.
Increase.
That is taking appointment times for patients that we may have seen in years past for any other myriad of reasons. So, but it's interesting.
Okay.
Okay, so moving on to the third page, we are looking at payer demographics. And this has the COVID population removed. So this is hopefully a more close representation of across the 3 years of our patient population. So starting with Medicaid, we've jumped about 6% in the last 3 years. Medicare has also increased about 7%. The really staggering data here is that self-pay population. That has decreased from about 34% to 20% in the last 3 years. So this kind of lends itself to possibly in that camp of Medicaid expansion. These would
federal impact.
absolutely. These would be the patients that in the past would be uninsured patients. So if we look at potentially the Medicaid expansion there, that's a big decrease in the amount of just uninsured, uncovered patients that we've seen in the clinic over the last 3 years. VA, while those percentages are zero, they just make up such a small percentage of our patient population that they don't even equal 1%. We saw 48 patients in 3 years total with VA benefits. And private insurance, so your Blue Cross, Blue Shield, Humana, any of those, that's really remained consistent over the 3 years, so not a big change there. Sliding fee, we have 3 programs that we offer in the clinic that fall within that sliding fee eligibility. The sliding fee tables that we use are based on the federal poverty guidelines. So these would be patients that we're seeing for STD. They're eligible for up to a 50% slide. Our family planning patients are eligible up to 100% slide. And then Care Plus patients. So again, that patient population that's here for anything not related to one of our specific grants or services are eligible to up to a 50% slide as well. That next page is kind of a comparison of the 3 years, and this is the sliding fee data. So, and this is across all PhD programs. So tremendous jump in patients. From 2019, we saw 11,237 patients. Of those, patients receiving a slide were 1,385. And then the dollar amount that we waived for those patients was about $285,000. If you compare that to 2021, we saw 16,334 patients, so a tremendous increase. However, again, if you look at the yellow line at the bottom, 6,500 of those were COVID patients as well. But of those patients, the patients receiving a slide in 2021 were only 643, so that is a substantial drop. And the amount of fee charges that we waived because of the sliding fee scale dropped $170,000 in that 3-year time period. So that dropped to $110,000. So that's a pretty significant change there. The next page, we're looking at uncollected charges. These would be patients that we sent to collections that we never received payment on. In 2019, that equaled just shy of $52,000. In 2021, only $26,000. So again, that amount was essentially cut in half.
Downtrend.
Yes, which again kind of lends itself to potentially that Medicaid expansion. Those typically would be the uninsured patients, the self-pay patients, and where so many people now have access to Medicaid that maybe didn't before, that could be a contributor to those decreasing numbers. And so just kind of in conclusion, that's what we're talking about here. Is it Medicaid expansion? Is it COVID? Again, I don't think we're going to know that until life comes back to normal someday and we can really look at the data and look at our changing patient demographics. In 2020, Idaho enacted the Medicaid expansion. So that kind of falls in line with some of the data that we're seeing. Potentially even when we talk about vaccines, if we have patients now who have Medicaid coverage that maybe didn't before, they are going out and they have access to providers in the community. So potentially those vaccines are taking place in the community and they're no longer coming to public health for that. And then the other is COVID. Of course, nationwide during the pandemic, overall healthcare use declined by 23 to 52% in 2020. So our decreasing patient totals really fall in line with the trends that I think everyone experienced across the country. So yeah, then there's a little summary of basically everything I just told you, but yeah, it's interesting data. So I would open it up for any questions if anyone has any questions.
Questions?
That's great information, I think, to know what we're doing and how we're addressing the demographics.
Mm-hmm.
Those in need. As public health, we're focusing on marginalized demographics. So going forward, those will help guide policy or decisions
I
for
absolutely agree.
new ways to reach out.
Yes, if our vaccine rates are in fact dropping by half, I think we have some work to do. So, yeah.
Any other questions around the table here? By the way, you realize that Jenna is a relatively new employee with us here at the Health District, but she speaks like a real veteran.
Oh, well, I appreciate that. I was caught off guard last time because I am so new here. So when Dr. McInders is asking me demographics, I just didn't have the information. But this was a really I really appreciated the opportunity to put this together and actually look at what is trending in the clinic. So
Very good.
I appreciate
Thank
that.
you. Well, Glenn, we're back to you again.
Let's see.
And after what you've just done, you may have very little to say.
Yeah. Okay, so my last executive council meeting was on May 12th. And the entire agenda was discuss the approval of meeting minutes from February 1st. That was approved. Discuss and determine a recommendation to the Idaho Association of Local Boards of Health on continuing to have a state association of local boards of health. And our discussion showed little interest in continuing to sponsor someone to go back to the National Association of Boards of Health. We didn't see much of a benefit in paying the travel costs and the hotel room, et cetera, because we didn't see a whole lot of benefit from the National Association. We see a much more benefit in the state of Idaho's districts getting together, discussing these issues, and working to resolve things. So we all put a nix on continued funding of a representative from the state of Idaho to go to the National Association of Boards of Health. And item number 3, discuss and determine a recommendation for the Idaho Association of District Boards of Health on pursuing legislation during the 2023 session to remove the food establishment license fee from Idaho Code. And that's part of what we were discussing today. And so we all determined, I think, that yes, we would like to see that removed from Idaho Code and come back to the local districts and counties. Okay, and that was pretty much it.
I
Any
appreciate
questions?
the comments about the National Association. You who have been around a few more years, that was Steve Scanlon's big thing.
It was his scam.
Yeah. And that was his free trip around the country.
And I think most of us recognize that. The great state of Idaho. Okay.
Thank you, Glenn. Well, go to tab 10 in your book. Christine, this is your chance.
Thank you, Mr. Chairman. Seems like we were just here and the month went by so quickly. And not much has changed in our financial story over the last couple of months. The significant change has been in our cash. If we look at our cash ending balance, and we're reporting on the 10 months ending April 30th. Our ending cash balance was $3,648,000. This is a decrease of approximately $1,400,000 compared to the fiscal year end, June 21. It leaves us with 3.2 months of cash in reserves prior to removing our board committed funds of $514,000 and program restricted funds of $196,000. Once we remove those two items, it brings our cash reserves down to 2.58 months. The reason why it dropped significantly over prior months, or the prior month,
is April had 3 pay periods. So that's represented in your 2.58. I anticipate by the end of June, we should be closer to the three-month mark. We've billed the counties. The counties were billed in April. We're starting to receive those payments. And I'm just making a rough estimate that June will end at 3.0 months. Before we move on to the budget to actual, let's put this on our radar for either our next meeting or sometime early in the new fiscal year. We take a look at our cash position and then we make a determination how much money we want to move to building maintenance, IT, vehicles. We've been putting about $45,000 a year into a fund for the 27th pay period, which should occur in 2027. This is the interest that is accumulating on our our committed funds. So we'll be having this discussion early in the new fiscal year. If there are no questions here, I'll just move on to our budget to actual. It's truly the same financial story that we've been hearing over the last 2 months. In our 12-month budget column here, the adjustments were made for the budget revision that we made last month, where we moved $325,000 in personnel budget expenses down to capital expenditures, and we had also moved $250,000 of budgeted items also down to capital expenditures and increased capital by $150,000 to absorb that large principal payment and the payoff of the Sandpoint facility. So that adjustment has been made. If we look at the activity as of the end of April, our revenue still remains under budget by $1.2 million. Same story. As far as the grants are related, we're still under budget in grants, and that goes to the staffing issues that we've been experiencing. Environmental fees are starting to come back up. We have that little seasonal lull. It's coming back up now, trending nicely. We were over budget in health service fees. The majority of that is due to the COVID-related admin fee that we can bill. But overall, in the grand picture, our revenue is under budget by $1,200,000. Even with the budget adjustment for personnel expenditures, we're still under budget by $225,600. Operating expenses under budget at $335,000. And I was curious earlier today to see if in line items, if we were over budget in fuel yet. And we're not. We still have about $42,000 in excess. So I was pleased to see that.
Can you project through the building season?
You know, I think that would be very, very difficult to do unless we look back at a comparable year, possibly. I think it would just be very challenging.
Fuel prices are record. There's no comparable year.
Yeah.
I'm gonna say, find us a
Yeah.
What year was it that we hit $5 per gallon? I read that last night. Was that back in 1996, 1997?
I don't recall.
Yeah, I just read that last night in the Wall Street Journal. I'll have to go back and refresh my memory on that.
Okay.
Capital expenditures, we're currently under budget by $46,000. Under budget for trustee benefit payments, $60,000. And if you'll remember, this is the contract that we chose not to renew in PHP. That was the trigger for the budget amount of $80,000. We elected not to renew that. The bulk of that was $80,000. We have some other trustee payments that pass through that are related to the Regional Behavioral Health Board. That's what represents those expenses there. So again, we are under budget by 60,000. So in total, we have a budget deficit of $529,000. Our actual deficit is $624,000. Keep in mind that we're cash basis, so we'll adjust here for our increase in accounts receivable, and that accounts receivable increase is primarily related to the quarterly payments to the counties, a good portion of it. So that brings us back to our beginning cash balance of $5,041,000. Once we add to that or subtract to that the change in accounts receivable and our actual deficit year to date, it brings us back to our ending cash balance as of April 30th of $3,600,000. Any questions?
Any other questions, comments? Yes, it's almost like you reported a month ago.
It very much is the
But,
same story.
Thank you for all your good work.
Thank you, Mr. Chairman.
Yes, indeed. Well, Mr. Duffy, do you think you need to have a moment here? This is your chance to shine.
Well, Mr. Chairman, I'll just take a quick minute. All of these items are quick. If you go on to tab 11, you will see our calendar year 21 annual report. And I see Kate. Kate, wave to the audience here. She's the one that put all this together for us. And I use this document that you see ahead of you when I go visit with county commissioners and give them an idea of how often their citizens are touching Panhandle Health District. So there's some incredible numbers in here. Thousands of individuals in 2021 took advantage of the services of PhD outside of their COVID-19. So wanted just to show you that document and have a moment for you to take a look at that.
Don, if I
Please.
overall, could you give us an idea of your meetings with the county commissioners regarding this next year's budget? How did that go?
Mr. Chairman, it went well. I felt that they were pleased with that we were practicing good financial principles. The fact that we could ask for an 8% in our salaries and only a 3% budget, really only a 3% of the 10% we were asking for an increase. I think they were pleased with that. I also shared these numbers for them, which for many, they were somewhat surprised of how often the citizens of their county were touching Panhandle Health District. The only challenge we had was their own budgets. They were looking at their own budgets with great concern of going forward. And there were some questions of how we could give an 8% salary increase, and they might not be able to, although we heard today that it sounds like many will be doing that. So that was a positive discussion that we had. So in my overall review, I think it goes well. And I think what really does help is our visits with them throughout the year, not just at budget time. And so when we come, there's some of that information they're already aware of.
Yeah, and I'd assumed that was their response because none of them showed up for this morning's budget big meeting. Well, there were a few that showed up, but I didn't see anybody from Bonner County. And so I was thinking they must have given a big thumbs up and they didn't need to attend.
Well, Mr. Chairman, that's what I'm going to believe, that's what happens. Yes,
Of
absolutely.
course, we know what an assumption does to these. Okay.
Well, Mr. Chairman, we had a good meeting with Bonner County, actually. All three of the commissioners were there, and it was positive and interactive.
Thank you.
Okay, our chairman talked a little bit about the IAB meeting in June 2023. And so again, this is a meeting where all of the members of all boards of health, all members of boards of health throughout the state come together. And it historically has been much, much more than a meeting of just looking at resolutions. A little bit of history, and our chairman is well aware that, and Michelle does have a lot of impact. And so it comes to our area once every 7 years. So it's coming up next year. And the last one we did, we from what I understand, I was not here at the time, or at least did not attend. We took them on a field trip. All got on a bus, and they went and looked at some of the great work we do with water quality and septic installations. And it was held actually in Kellogg at the resort up there at the Silver Mountain Resort. And from what I understand, it was a very productive meeting. I reached out to all of the district directors on Monday evening when I met with them and asked them their opinion. Are we ready to come back face to face? And it was an okay response. And their hesitancy was because they really weren't sure, right, how their boards of health would feel about that. I want to tell you that we are behind this. We think it's an important event to get them together. I think bringing them here will largely depend upon our agenda and what we're going to do. There were comments by district directors that if it's in Coeur d'Alene, more will come. And I believe that to be true if, in fact, the agenda is something that's interactive and will be helpful to those that would come and attend. So I would appreciate any thoughts from you. I don't see this, Mr. Chairman, as an action item, but I really would like your approval for us to go ahead and begin that. What that will mean is we will quickly pick some dates. I mean, like within the next month, try to tie down a location and send out some save the date cards to all of our Board of Health members within the next quarter for sure. So I just didn't know if there was any feedback. The only reason we've really been virtual was due to the pandemic. And prior to that time, those meetings were face to face. So any feedback you'd like to provide me before we move forward, or if we should move forward?
I'd like to ask Michelle, was the meeting at Kellogg Wallace, was that 2 sessions ago?
Mr. Chairman, correct. It was, and the last one was in Coeur d'Alene,
At the resort.
which wasn't so as exciting, but we did talk about that a little bit, but it wasn't as exciting as the Kellogg one.
But that Kellogg meeting, that went over really well, far better than we even anticipated. I was expecting some complaints for being so far away from the airport, clear up in the Silver Valley. But
Mr. Chairman, if I
But
may,
they-
we are good hosts in Shoshone.
what's that?
We are good hosts in Shoshone.
Yes, you are. Yeah. They didn't seem to mind at all coming to Silver Valley. But we rented this bus, took them up Burke Canyon. And if you haven't ever had a Burke Canyon experience, you need to. And then over the golf course that was built on the old dump site, and that was first-hand experience, and it was pretty hard to improve on first-hand experience. Yes, but the last one, 6 years ago, was at the Coeur d'Alene Resort. We did it 1 year at Templin's. I know it costs a little bit more, but I think there is some value in coming together.
May want to consider Schweitzer Mountain this time.
I don't know, where is that?
For the $700 rooms, you mean?
Minimum.
We could house them down below and have the meetings up there and there.
In the firehouse at the roundabout.
They've got a conventions type area now. So. It's got a beautiful view anyway.
All right, well, thank you, Mr. Chairman, and all of you. We'll go ahead and pursue that meeting, and I'm hoping that we can take all of our Board of Health members zip lining. That would be fun in the Silver Valley.
That would be fun.
So also, just a reminder that at our July Board of Health meeting, it'll be a day of election of officers. That will be for chairman, vice chairman, and trustee to the executive council. Just nothing you need to do about that. Just be aware that those elections will take place on our July meeting. Also in our July meeting, both Glenn Bailey and Dr. Fletcher will both be up for being back on the board. And again, that process is simply we go to, in this case, just the Bonner County Commissioners, and they submit the names, and those names are voted on by all 15 commissioners throughout Panhandle Health District. So those two items are coming up in July. And then finally, if you look in your packet, there is a report that shows, speaking of Board of Health members, a history going way back. And you can thumb through and take a look at that document. It's, let's see here, where did that go?
Oh, it's
There we go.
tab 10 way, or no, 11 way in the back.
161.
Yeah, and it's front and back, and there's quite a history there, without a doubt. Might be a bit of interesting for you to take a look at. And Mr. Chairman, that's the end of my report, unless there's any questions.
All right. Any comments, questions on the director's report? That brings us to the end of our agenda. I would remind you again that the June 9 IAB, get your proxies into Glenn. And following that, the next regular board meeting for this body is July the 28th. All right, anything else to come before this board at this time? If not, we are adjourned. Thank you for your participation, for your attendance, both at the meeting earlier today and to this meeting.